Chapter 49, The Child Alteration in Tissue Integrity. Your book has some good photos of many of the skin problems we are focusing on. Seborrheic dermatitis is a chronic inflammatory skin condition seen frequently in infants. It's referred to as cradle cap when located on the scalp. It often begins on the first 2 to 3 weeks of life and usually disappears by age 12 months. Seborrhea in older children might appear on the face, behind the ears, around the umbilicus, or any other area with a large number of sebaceous glands. Although the precise cause is unknown, seborrhea appears to be related to sebaceous gland dysfunction and overgrowth of fungi. Manifestations include non-itchy, yellow, oily scales. Erythema is commonly present in the diaper and around the umbilicus. Areas can be inflamed and secondary infections can occur. The nurse inspects the infant's scalp or other affected areas for lesions and inflammation and questions parents about the frequency and technique of washing the infant's scalp. Instruct the parents to remove the scales daily by shampooing with the mild baby shampoo or an over-the-counter anti-seborrheic shampoo. Massaging the scalp with the warm mineral oil before shampooing helps loosen the scales. Using a fine-tooth comb or a clean, soft bristle toothbrush during the shampoo also will help loosen the scales. Teach the parents the importance of the good hygiene when caring for the infant's scalp and to skin to prevent reoccurrence. Reassure them that the fontanelle is not fragile and will not be damaged by gentle pressure and washing. Advise the parents to contact the physician if the site becomes infected. Skin lesions that do not clear with frequent washing can be treated with hydrocortisone cream applied twice a day. Contact dermatitis is a skin inflammation that results from direct skin to irritant contact. Contact dermatitis can be caused by hundreds of substances. Diaper dermatitis, known as diaper rash, is a contact dermatitis from irritants such as moisture, friction, and chemical substances. Urine ammonia formed from the breakdown of urea by fecal bacteria is extremely irritating to sensitive infant skin. Ammonia alone does not cause the skin breakdown. Only skin damaged by infrequent diapering changes and constant urine and feces contact is prone to damage from the ammonia in the urine. Inadequate fluid intake, heat, and detergents in diapers aggravate the conditions. Manifestations of irritant contact dermatitis include a dry, inflamed, and pruritic skin. The distribution of lesions correlates with the skin surface in contact with the offending agent. Diaper dermatitis begins with erythema in the perianal region and can progress to macules and papules, which form from erosion and crust. Manifestations of allergic contact dermatitis include blistering, weeping lesions over an area of the inflamed skin, intense pruritus, and crusted scaly lesions that heal in 10 to 14 days without treatment. The characteristic appearance of the lesions and a history of exposure to an irritating substance establishes the diagnosis. Skin testing might be performed in children with persistent or recurrent dermatitis. Discontinuing exposure to the offending agent treats contact dermatitis. The skin should be washed thoroughly if any irritant remains on the skin. Cool compresses of tap water or Burroughs solution or a steroid cream may be applied several times a day after application of the compress. Severe contact dermatitis might require treatment with oral steroids. Atopic dermatitis or eczema is a common chronic inflammatory disease of the skin characterized by severe pruritus. Atopic dermatitis can have distressing psychosocial effects on the child and family. The cause of the atopic dermatitis is unknown, but the disease is thought to be genetically determined and related to a malfunction in the body's immune system. Children with atopic dermatitis may present with asthma or allergic rhinitis. During infancy, the erythematous areas of oozing and crusting appear first on the cheeks and then on the forehead, scalp, and extensor surfaces of the arms and legs. The affected scalp area resembles seborrheic dermatitis, but unlike the seborrheic dermatitis, atopic dermatitis is intensely pruritic. Infants begin manifesting symptoms at approximately age 1 to 4 months. Children and adolescents with atopic dermatitis readily experience intense itching, especially in response to sweating or contact with irritating fabrics. Dry skin is a hallmark of this condition. The diagnosis is based on the clinical features of the intense pruritus, the appearance of the lesions, the pattern of remissions and exasperation, and a family history of allergy. IgE levels and eosinophils are often elevated. Skin testing for food allergies, usually milk, eggs, wheat, soy, peanuts, and fish, can help identify potential food triggers. The main goal of treatment are to control itching and scratching, moisturize the skin, prevent secondary infection, and remove irritants and allergens. Control of pruritus includes avoiding those environmental triggers, such as overheating, soaps, wool clothing, and other skin irritants. Oral antihistamines may be used to control the itching. Therapeutic management includes proper skin hydration is essential. Either a dry or wet approach can be used. The dry approach depends on avoiding bathing and the liberal use of emollients on dry skin. The wet approach is currently more popular. It permits bathing for limited periods and then the use of wet compresses and occlusive creams and ointments are the mainstay of treatment. In humid climates, bathing should be infrequent and only lukewarm water and mild. Non-perfumed soap, for example, Purpose, White Dove, or Basis, should be used. Emollients such as eucerin cream or petroleum jelly applied to the damp skin immediately after bathing helps the skin retain the moisture. Applying the moisturizer while the skin is still damp hydrates the skin. Anti-inflammatory corticosteroid creams and ointments are prescribed for inflamed areas. Identifying and eliminate allergens can be helpful. Impetigo can often occur as a secondary infection from another skin lesion, such as an insect bite. Close contact contributes to the spread of impetigo, which is highly contagious. Children in daycare facilities, schools, or camps, and athletes are at increased risk. The incubation period for impetigo is 7 to 10 days, and it can spread to other parts of the child's skin or to others who touch the child, or if they use the same towel or drink from the same glass. Spread of the infection is fostered by poor hygiene, crowded living conditions, and a hot, humid environment. Lesions will resolve in 12 to 14 days with treatment. Manifestations are small vesicles that are initially filled with serous fluid and later become pustular. They rapidly rupture, leaving a shiny, lacquered-appearing lesion surrounded by a scaly rim. Crusted impetigo appears initially as a vesicle or pustule that ruptures to become an erosion with an overlay of honey-colored crust. The erosions bleed easily when those crusts are removed. The characteristic appearance of the lesions usually confirms the diagnosis. Impetigo is treated with topical and oral antibiotics. The lesion should be gently washed 3 times a day with warm soapy washcloth and crusts soaked and carefully removed. A topical ointment is then applied to the lesions. Topical therapy lasts 7 to 10 days. Severe cases of impetigo or cases of impetigo around the mouth are treated with oral antibiotics that are effective against both staphylococcal and streptococcal organisms. Teach parents to soak the crust and then wash them off with the warm soapy washcloth 3 times a day. Advise them to gently remove the crust after soaking, taking care not to spread the infection to other parts of the body with the contaminated washcloth. Antibiotic ointment should be then applied to the lesions and the affected areas left open to air. A small amount of bleeding after the crust removal is common. The child should sleep alone and should be bathed daily, alone, with an antibacterial soap. The caregiver should wear gloves when caring for the child. Emphasize the importance of administering the full course of topical or systemic antibiotics as prescribed. Thrush, which is oral candidus, there's a picture of that in your book, is a superficial fungal infection of the oral mucosa membrane that's common in infants. Thrush occurs as a result of overgrowth of C. albicans. In addition to the oral lesions, the child may exhibit lesions in the diaper area, which are caused by C. albicans passing through the intestine. Moisture and heat in the diaper area create an environment favorable to the development of Candida dermatitis. A neonate can acquire candidus during delivery while passing through an infected vagina. An older infant can have a fungal overgrowth as a result of an immunosuppression during antibiotic therapy, from exposure to the mother's infected breast, or from unclean bottles and pacifiers. White curd-like plaques are noted on the tongue, gums, and buccal mucosa in children with thrush. They can be distinguished from milk curds by the difficulty encountered in removing them and the bleeding of the erythematous base when plaques are removed. The lesions of Candida diaper dermatitis are usually bright red. The diagnosis of thrush and Candida diaper dermatitis is made from the clinical appearance of the lesions. Nystatin oral suspension, 100,000 units per ml, swabbed on the mucous membranes of the mouth is effective in treating thrush. Because Candida is present within the GI tract, oral nystatin is often prescribed to decrease the likelihood of recurrence. Oral fluclazone is also an alternative therapy. Candidal diaper dermatitis is treated with topical antifungal agent such as nystatin. To increase the amount of time the medication is in contact with the mucous membranes, nystatin should be applied after feedings. Pacifiers, nipples, and bottles should be thoroughly cleaned to decrease the chance of reinfection. Teach the parents the techniques and importance of good hand hygiene. If the infant is breastfed, the mother's breast should also be treated with nystatin. Tinea is a superficial skin infection caused by a group of fungi known as dermophysites. Tinea corpus, which is ringworm, is a fungal infection of the face, trunk, or extremities. It can be transmitted by humans or dogs and cats. Most lesions of Tinea corpus clear without treatment in several months, but some may become chronic. Tinea curius, which is known as jock itch, is characterized by an intense inflammatory reaction with severe pruritus. Tinea pedis is athlete's foot, can become chronic, particularly in adolescents who wear unventilated athletic shoes. Common manifestations of the tinea capitis include erythema and scaling of the scalp and one or more round patches of alopecia that slowly increase in size. Small papules at the base of the hair follicles become crusting pustules and red scales. In some cases, thick broken hairs close to the scalp surface result in patches of black dotted alopecia. Manifestations of the tinea curius include pink papules and scales on the inner thighs, groin, scrotum, and buttocks, but not the penis. Pruritus is also present. Tinea pedis, commonly referred to as athlete's foot, produces fine, vascular pustular or scaly lesions on the sole of the feet, between the toes, and under the nails. Most tinea infections can be diagnosed from the clinical appearance of the lesions. Therapeutic management of tinea capitis involves medication that must penetrate the hair follicles. Topical therapy alone is not effective for tinea capitis. Oral grisofluven, administered daily for at least 6 weeks, is the treatment of choice. It's the only drug approved by the FDA for treating tinea capitis. Tinea curius treatment is topical antifungal preparations, and they should be applied twice a day to the lesions and at least 1 inch beyond the borders. Care should be given to apply the medication to all creases, and the adolescent should be advised to wear loose clothing. Treatment for tinea pedis is a prescribed topical antifungal agent which is applied twice a day until the lesions have been cleared for 1 week. Lice live only on humans and are transmitted by direct contact with the infected person and contact with infested objects like brushes, hats. Lice cannot jump like fleas, and clean hair is no deterrent to head lice. Nits are visible and attached firmly to the hair shaft near the scalp. They are tiny, silvery or grayish and white specks resembling dandruff, but they are more difficult to remove. They are commonly found behind the ears and at the nape of the neck. Adult lice are difficult to see because of their small size and the fact that they crawl very fast to avoid light. Scattered lesions on the scalp, behind the ears, or on the back of the neck cause intense pruritus. Secondary scalp infections can develop from scratching. The diagnosis of head lice is made by identification of the nits or lice on the scalp. The examiner parts the hair with 2 tongue depressors and moves from side to side and front to back, paying particular attention to the crown, behind the ears, and the nape of the neck. Unlike dandruff, nits are not easily removed from the hair shaft. Management of the child with lice focuses primarily on killing the active lice and nits and preventing spread or recurrence and managing the environment. An over-the-counter pedicule, pyrethyrmin 1%, which is like Nix, Eliminate, Actin, kills head lice and pubic lice in eggs with 1 application and has residual activity, which means basically it stays in the hair after treatment for 10 days. Nix cream rinse is applied to the hair after washing with a conditioner-free shampoo. Cream rinse or lotion should be rinsed out after 10 minutes. The hair should not be shampooed for 24 hours after the treatment. Even though the kill rate is high and there's a residual action, treat the hair again after 7 to 9 days using a fine-tooth knit comb on wet, conditioned hair at least 4 times over a 2-week period is an evidence-based recommendation. Environmental objects, clothing, bedding should be treated or washed. It's important to examine family members and others who might be in close contact with the infested child. Only those with an observed infestation should be treated. The parents need to notify the school if the child has an active case. Meticulous vacuuming of carpets in the classroom with affected children will help prevent transmission. Advise parents to wash clothing, especially hats and jackets, bedding, linens, in hot water and dry them in a hot dryer setting. Dress-up clothes, hair ornaments, bicycle helmets, batting helmets, headphones, and similar objects should also be treated. Items that cannot be washed should be dry cleaned or sealed in plastic bags for 2 to 3 weeks. Anti-lice sprays used for furniture and other environmental objects should never be used on a child. Thorough home cleaning is necessary to remove any remaining lice or nits. The parent should vacuum floors, play areas, and furniture to remove any hairs that might carry live nits. Combs and brushes should be boiled or soaked in an anti-lice shampoo or hot water. Has to be greater than 140 degrees for at least 10 minutes. Routinely, teach children not to share hats, combs, or hair ornaments with other children. At school, individually assigned lockers or separate hooks for coats can help inhibit the spread of lice. Scabies is a contagious condition that's been recognized for many centuries. It results from the infestation with Cercospes scabies, the itch mite. Scabies is transmitted by close personal contact with an infected person. Those who share a bed or live in a crowded condition are likely to transmit scabies to each other. The scabies mite cannot survive for more than 3 days away from human skin. Intense pruritus occurs, especially at night. Infants may be cranky, sleep fitfully, and rub their hands and feet together. Burrows, which are fine, grayish, thread-like lines, can be difficult to see because they are usually obscured by secondary changes in excoriation and inflammation. Papule vesicles and nodules are common and are located mainly on the wrist, in the finger webs, and on the elbow, in the umbilicus, in the axilla, in the groin, and on the buttocks. In infants, the head, palms, and soles may be affected. The characteristic skin eruption and history of an intense pruritus, especially at night, are suggestive of scabies. The diagnosis is made by microscopic examination of scrapings of the lesion. Scabies can be treated with topical application of permethrin 5%. The medication is applied to the body and head, depending upon the age, avoiding the eyes and mouth. The medication must remain on the child for 8 to 14 hours, depending on the medication prescribed, to be effective. So applying at bedtime is recommended. It is washed off in the morning. Retreatment in 1 week is usually recommended. Pruritus lasts for several days to weeks after treatment and can be relieved with corticosteroid cream, like hydrocortisone, and oral antihistamines. Family members, even if asymptomatic, and daycare contacts, except for pregnant women, should also be treated. The child's bedding and clothing should be washed in hot water in a fashion similar to the environmental treatment for lice. Nursing care of the child and family with scabies is similar to that with lice as well. Inspect the child's hands, elbows, umbilicus, groin, and buttocks for burrows. However, burrows are sometimes difficult to see, and persistent itching may be the only symptom. Advise the parents that a persistent itching after treatment is expected for approximately 2 weeks and is not a sign of reinfestation or an indication for repeated application. Acne is a disorder of sebaceous hair follicles. Although acne is greater perceived as a minor disorder, it can cause significant anxiety and emotional pain for the affected adolescent. The disfiguring lesions of acne can lead to physical and emotional scarring. Acne consists of closed whiteheads, blackheads, papules, pustules, nodules, and cysts. Not all adolescents have all types of acne, and treatment is based on the type of acne. The areas most affected are the face, neck, back, shoulders, and upper chest. The diagnosis is based on examination of the lesions and the child's history. The goal of treatment is to prevent scarring and to promote positive self-image in the adolescent. Treatment must be individualized according to the severity of the condition, the types of lesion present, and the adolescent's gender. Improvement usually begins in 4 to 6 weeks, so the adolescent needs support to keep from feeling discouraged after treatment begins. 3 to 5 months are needed for optimal results. Topical therapy with a variety of agents is a primary treatment for acne.